I promise I'll make this kind of quick. It's just two really interesting sisters who appeared in sequential, pregnancies in my practice. So before anybody has a fit, Mom gave me the pictures. It's all okay. She doesn't care that they're up here. So this is a tale of two cute little blonde girls, as you can see. The older one here is Kaisley. This is Renly. And her mom was one of my first patients when I opened my doors in late 2019. So at the time, she was a 24-year-old prima gravida, really referred just for a routine anatomic survey. We first saw her at 18 weeks. Very benign history, no family history of CHD, no exposures, nothing really to report. And I don't include the pictures of fighting with this kid for the first 20 minutes that we scanned her, but baby was chest down, and it was, when you see the diagnosis, you'll see how tempting it was to say, oh, that looks okay, and then baby turned over and I went, oh, thank God I didn't do that. So baby turned over, and the first thing we did trying to get aortic and ductal arches, as you see here, we have a nice aortic arch that has anterograde flow, looks good. But typically right over here, going back and forth, you would expect to see a ductal arch going from the right ventricle, kind of more sloping backwards. We don't have that. Instead, we have this additional little vessel here that's kind of got to and fro flow and a bit bigger than normal. So obviously, once we waited for baby to turn over, this is going up into the 3-vessel view above the heart. So here we have, for all of those who this is not immediately obvious to, we have a dilated main pulmonary artery over here with branch PAs. You can see the pulmonary valve here is rudimentary with kind of nubbins for leaflets, with this being into the right ventricle. A little bit different view here. So large aneurysmally dilated confluent branch PAs. Pulmonary valve shows really no discrete opening and closing. It's just kind of a rudimentary wide open valve. Producing large to and fro flow, which is typical of this particular lesion, which we'll get into in a second. So very high velocity to and fro flow. The regurgitation, or the flow back into the right ventricle, is what accounts for the dilated right ventricle in this pathology, and we'll look at that in just a second. So here a little bit later in pregnancy, here's your kind of 4-chamber view going up a little bit into your LVOT. You can see we have an overriding aorta, or anterior malalignment VSD. Here's the aortic valve right over here, and a preferentially dilated or volume loaded right ventricle, because it's getting all that regurgitation through the incompetent pulmonary valve. The heart itself is also a little bit enlarged, and what you're seeing here is really just kind of cutting a little bit of those two dilated aneurysmal pulmonary arteries. Maybe a little bit of tricuspid regurgitation, but not horrible. Here's a little bit later in pregnancy. You can see the Z-scores on the RPA and the LPA is 6 to 7, depending on what you're using for your reference point. Here again is a little bit of a look in still time at your pulmonary valve, which shows these little rudimentary but non-competent leaflets. As pregnancy progresses, the velocity increases to and fro flow, so you can see the regurgitant velocity max is just about 200, as is the anterograde flow. Same continuing later on to the 3rd trimester. What you see here is actually baby did really well in the sense of no hydrops, no effusions, remains with, dilated right ventricle with some depressed function, some cardiomegaly, but otherwise was growing well and did well. So here again is your dilated right ventricle, because it's volume loaded based on this regurgitation, your dilated branch pulmonary arteries, and here looking at your your pulmonary valve, not much in the way of effective closure. Again, I mentioned earlier in my first talk that one of the potent clues to looking at any of these outflow tract abnormalities is a left axis deviation. Here you can see somewhere around 29, 30 weeks, we were at 79 degrees for left axis deviation. Aorta remained fairly large, Z-score just a little bit over 3, with good forward flow, widely patent arch, no concerns for the aorta. And again, mildly enlarged right ventricle, but otherwise good function. And here's our dilated aneurysmal PAs. Really good view here looking at essentially the non-pulmonary valve. So for those of you who haven't figured this out, this is tetralogy or TET absent pulmonary valve syndrome. Again, very, very dilated branch PAs with to and fro flow. So the diagnosis was of tetralogy with absent pulmonary valve. As is very common with this disorder, when there's a VSD present, there was no ductus arteriosus. Baby was born at 39 weeks, a little bit on the smaller side, but the whole family is fairly petite. At the time had hypoxia requiring intubation, had a stent placed in the right outflow to improve SATs, but no bronchial narrowing, did fine from a respiratory standpoint. Initially had mild to moderate RV dilation with low normal function, but progressively over time developed some stent narrowing with a gradient and had a definitive repair at several months of life with RV outflow tract stenting, pulmonary arterioplasty, VSD repair, and a right ventricle to PA conduit. Baby's done really well, as you saw in the picture, post-operatively. She had a little bit of left mainstem bronchus compression that resolved, but otherwise is a happy, healthy kid. So you can appreciate parents' concern over the next pregnancy of what is the likelihood this is going to happen again. I should also mention, I didn't include it in this, but to the extent that it's helpful, normal NIPT, including microdeletion panel, 22q negative, and at the time of delivery, no other evidence of dysmorphology or concern for another genetic syndrome. So now she's age 4, as you saw, no meds, no intracardiac shunts, a little bit of pulmonary valve thickening with mild stenosis, but again, developmentally meeting all her milestones. She's petite, but super beautiful and looks great. So then mom comes back for the next pregnancy at 12 weeks, like we talked about, early assessment, nuchal translucency. Her previous child is the one we just reviewed with absent pulmonary valve. So at 12 and 4, you can see really nice normal nuchal translucency, which again is, not a perfect tool, but is reassuring in terms of congenital heart disease if it's nice and normal. This is our first 3-vessel view. So here we have, pulmonary artery, aorta, transverse arch, anterograde flow, but something is a little bit atypical about this appearance, right? That looks a little bit more like a Y than the V that should meet on the left side of the trachea. And normally you get that V-shaped impression because there's a ductus arteriosus over here that we're just not really getting a hint exists with this 3-vessel view. Interestingly, just to follow up on the lecture that Alfred just gave you, this baby also had agenesis of the ductus venosus, had the umbilical vein that ends blindly in the liver. Presumed return of the flow is through to intrahepatic shunts that are too small to be seen by ultrasound, but here is the hepatic vein, and we don't have connection of the ductus venosus to the hepatic vein. Again, I felt like this was deja vu all over again, right? Here we have a nice aortic arch, but we're not getting the ductal arch. So again, at 16 weeks, we're pretty concerned that we have an absent ductus arteriosus. Stay tuned for the final pathology. So what does that start to look like to people? An overriding aorta, right? So we have nice ventricular inflow. Left axis actually isn't too bad in this baby. I think it was fairly normal, but we're getting this real impression of confluence of both ventricles into a single or overriding outflow, which I think you can see a little bit more here. So by 16 weeks, we have an anterior malalignment VSD, or an overriding aorta. We have no ductus arteriosus. And mom is saying, oh my God, here we go all over again. What are the odds? A little bit later in pregnancy, you can see that the size of the pulmonary artery gets a little bit smaller relative-wise, which is common with tetralogy. It may not be as stenotic or as underdeveloped early on in pregnancy. We're coming up into our 3-vessel view. We have a transverse aortic arch with anterograde flow that's good size, but this tends to kind of stop right where you would expect the ductus arteriosus to join the descending aorta. Again here, pulmonary artery not bad in size, anterograde flow, not seeing a good connection of the ductus arteriosus to the descending aorta. Again, nice confluent branch PAs, a little bit of stenosis, no ductus arteriosus. Views towards the end of pregnancy, larger aorta, smaller pulmonary artery with confluent branch PAs, absent ductus arteriosus, and here's our overriding aorta or anterior malalignment VSD. So the diagnosis was more of a classic tetralogy of Fallot, mildly hypoplastic PAs but with anterograde flow, agenesis of the ductus venosus with an intrahepatic shunt, and again, absent ductus arteriosus. Baby was born at 39 weeks, again, fairly petite like her sister, had bidirectional shunting across the VSD, moderate infundibular stenosis, mild to moderate PA stenosis, eventually evolving to more severe, had repair tetralogy of Fallot. I'll leave this up here just because it's the surgical impression. Doing well now, normal LV size and function, repaired VSD, widely patent branch PAs. So I brought this up really just to show you that it's intriguing to have two variations of fairly rare presentations of tetralogy in the exact same family. If anybody has any ideas, they're super motivated to have exome or genome or anything done that somebody is willing to do to look at their two girls. But they're beautiful kids, and just, don't ever think you're out of the woods.